Hello, everyone. It's really good to see all of you today. So, for today, we have Dr. Aju with us, who would be the faculty, and he would be talking on pain and its impact. Dr. Aju Mathew is currently serving as an American board certified medical oncologist and hematologist, and he's also an attending physician at the National Cancer Institute. He was also the co-director of the Hematology Oncology Fellowship Training Program. He is also an adjunct faculty at Kasturba Medical College, Manipal. After graduating in medicine from the Government Medical College Trivandrum in Kerala, he has attained further training in Cambridge University and a lot of other international universities. He is also published in some major high-impact journals in the field of medicine. He is also an award winner from the American Society of Clinical Oncology and American Association of Cancer Research for his research work. We are so pleased to have you, Dr. Aju, with us. Thank you for joining us. Over to you.
Thank you so much. It is always a pleasure to talk to the participants of the course hosted by Talim India. Talim India is an organization that is very close to my heart. It's very nice to see all of you. Slowly but steadily, we are reaching out to hundreds of people like you, professionals, lay persons, patients, to reach our goal of a pain-free or a painless India. I don't think pain-free is really a possibility, but painless India. So anyway, I'm very happy to see all of you. I'm sure all of you are in various stages of your career and of different types of professions and volunteerism. Please interrupt me if you have any questions. I'm happy to be interrupted. We can have a conversation. If my language is not very clear, please interrupt me, let me know. I'm familiar with English, Malayalam, and a little bit of Hindi. So let's start off with my slides. I don't usually use a lot of slides, so it's going to be more of conversation. So again, interrupt me when you have a question. So pain and its impact. I don't think if any living person would have any doubt that pain has a substantial impact on a person. And I believe 100% of us have experienced pain in one way or the other. I mean, it's said that without pain, there is no life. And you know very well that the consequence of having no pain can be significant on a person. The classic example is that of leprosy. In patients with leprosy, they lose their nerve fibers and the pain relaying system. So even if they touch a hot kettle, they may not feel the heat, and therefore they may burn their fingers. Some patients with diabetes, when their neuropathy is significantly bad, may have substantial impact as a result. So it is very obvious that pain and its impact on a person in society is quite bad. Now, to broadly categorize the impact on of pain, I would like to divide it into three. One, a physical well-being. Pain impacts a person's well-being in a physical sense, emotional well-being in an emotional sense, and social well-being, how that person exists in society. Physical well-being, emotional well-being, and social well-being. So what is pain? Pain is a sensory experience associated with tissue damage. So I touch something, it hurts. I mean, the sensation is not pleasant. There could be some tissue damage, that can come out of it, and that experience varies from person to person and from time to time. Now, some person may say, I can take multiple number of pokes in the skin for an IV line, whereas some of my patients, they don't even want to come with their skin poked for an IV line. So the experience varies from person to person, and from time to time, some patients may get increasingly used to pain, some may not. The key thing that I would like you all to remember from today's class is that pain is not just a sensory experience. Pain is an emotional experience as well. And that's where sometimes it is very difficult to objectively measure pain. And therefore, one of the crucial lessons that every person involved with palliative care and pain management learns or should learn is that you and I should believe the patient when they say they are in pain. So what is the one thing you need to know? That if the patient says they are in pain, believe it, they are in pain. So pain is what the patient says it is. Subjectively, different people show pain in different ways. People experience pain differently, right? I mean, all of us know. I, for instance, if I go to the dental surgeon, I would come back crying. But I know people, some of us who can go to the dental surgeon and have all 32 tooth extracted without any local anesthetic. I hate dentists, by the way. If there are any dentists, apologies. So people experience pain differently. One person's report of severe pain may seem like almost nothing compared to another. So the caregiver's challenge, that is the person who's taking care of the patient at home or in society, or a doctor or a nurse, our challenge is to assess all the relevant factors without imposing personal biases. I was just witness to one of my surgeons actually putting an intercostal chest tube drainage yesterday. I mean, absolutely poor pain control. It's as though he didn't believe in pain control. The point is, he feels probably rightly that it only takes maybe 2 minutes of intense pain, and things should be fine. But so the person, the caregiver's challenge is, we probably would not know how much pain a patient can handle. So I think it's important that we discuss with the patient, do everything to mitigate the pain risk that the person may have. Person's self-report of pain is the single most reliable indicator of pain. There is no other definition, there is no other measurement or a lab test that can tell you whether a patient is in pain. The psychological factors that can interfere, interact, and modulate pain are various: emotions, cognition, that is intellect, personality, a person's response, coping techniques. Some patients may talk about meditation to alleviate pain, to modulate pain. Illness behavior, some may withdraw, some may be more outspoken, some may curse. So pain experience is an interplay of several of these factors. A lot of these factors come together to actually interplay to modulate pain. So the same kind of pain for a person may vary from today to tomorrow. But there are some objective indicators of whether a patient is in pain, especially in those who have difficulty in expressing. For instance, my youngest son, he's 7 months old, is now currently suffering from Takalipani. I don't know if there are enough Malayalis here. It's otherwise called hand, foot, mouth disease. So there are not much lesions on the outside, but the poor chap, 7 months old, is crying. He can't express pain. So his threshold of pain is crying. His indicator of pain is crying. So we gave him some ibuprofen with a little bit of paracetamol, and he's very comfortable, sleeps well, comfortable, feels well. High heart rate, tachypnea, restlessness, groaning, grimacing. These are sort of things that we classically see. But at the same time, sometimes some patients may show resistance to care. They may not come see a doctor on time. They may withdraw themselves from social interactions. They may not eat. They may have sleeping trouble. These are all indicators of pain. Now, when pain is not treated properly, they may have poor appetite, weight loss, disturbed sleep. They may withdraw from social activities, sadness, anxiety, aggression, and difficulty walking or transferring may become bedbound. So it is very important that we treat pain well. Dame Cicely Saunders, who's sort of thought of as the main person, the real, the original, father or the mother of palliative care, as some may say, defined the concept of total pain as a suffering that encompasses all of a person's physical, psychological, social, spiritual, and practical struggles. So patients' physical struggles one side, social, financial struggle one side, emotional struggle one side, spiritual struggle one side. So all of these taken together is the concept of total pain. So the point that I always learn whenever I see this slide is that pain or total pain is something that I must keep in consideration when I see a patient, and I must put an emphasis on attending their physical needs, their social needs, their emotional needs, and their spiritual well-being as well. Now, some of you may be atheist may believe in atheism. So, do you have spirituality? I don't know, but most of us have some spiritual beliefs. I believe even atheism, those who practice atheism also have spiritual beliefs. So, putting all this together is what we call a total pain. The objective of what a treatment is not just pain relief. That is, if you try to address the total pain, it's not just to address the pain that they feel, but to improve their quality of life. Now, as a doctor, I always do this when I try to see a patient who has pain. I see in two columns, is this a pain that can be treated and healed? Or is this a pain that can be treated and palliated? The classic example of treated and pain and healed is two things. I have a toothache, I go to the dentist pulls my teeth and it's gone. The pain is gone. But some pain with cancer, the pain can never completely resolve. So you have to control or palliate. So whenever I see a patient, I try to think, is this something that I can completely heal? Or is this something I can palliate? It's very important for me to address these so that I can then decide how to diagnose why the patient is in pain. So the importance of proper diagnosis through examination, investigations, asking, talking to patient, and getting access to proper treatment. Now, the vast majority of Indians they have facility to get diagnosis, but do not have access to proper treatment. When I say proper treatment, pain management, even those who are the most affluent sections of a society. Patient in Kochi who goes to the corporate hospital that is next door may not get good pain relief, but they come to the smallest primary health center, they get good pain relief. So one person's, when I say access to proper treatment, I'm not talking about their financial metal. I'm talking about their access to proper treatment, as in, are they getting the sort of resources that they need to diagnose, treat, and understand how to alleviate their pain. So how do patients get treated? Sometimes when they have pain, surgery. Sometimes when they have pancreatic cancer pain, we take care of the pain by putting a nerve block in the celiac plexus. We give a block. Block is you inject some local anesthetic to that nerve plexus so that that area becomes numb. Sometimes we give them balms, that is called topical. We give them IV or IM injections, that's called parenteral. Sometimes acupuncture, integrative medicine can help. Sometimes supportive care, splinting, bracing can help. Psychological care, example, counseling, and those kind of therapy can also help. But most important is to listen. It is very important that a person actually, that the physician actually listens to a person's symptom or problems and then address the issue. Now, would you just excuse me for a very quick second? I just need to answer a phone call. Thank you. It's going to be a very quick phone call. So the most important thing is to listen. Now, in terms of medications, we need to treat pain early. In continuous pain, analgesics should be given on a continuous basis, depending on duration of action of each other. So these are things that you would all learn in the coming days. You have to understand how much time a medicine works and have to give continuous pain medications. And you have to rely on what we call an analgesic ladder. So initially we start off, if a patient is in pain and they need medicines, we start off with the lowest threshold, lowest intensity pain medicine that is called non-opioid. Then we go for weaker opioid, and then we go for stronger opioid. So the key thing you need to realize is, as the pain increases, we have to climb up the ladder and use the most powerful pain medicines. And the key thing to realize when we dispense pain medications is that ideally it should be given by mouth. It should be given by the clock in regular intervals, and by the ladder, as in when intensity increases, therefore we will increase the strength of the pain medicines. It should be individualized, and we should pay close attention to detail. Now, I'm going to stop my lecture here. Now, I'm going to discuss a few cases very briefly, just to give you a picture of how I study pain in my practice. Case number one is when a patient of mine came to see me. The family asked me, hey, can you see our maid who has pain, headache? we have been advised to do an MRI scan. So can you write a prescription for an MRI scan to look at the headache? So I said, let me, before I order an MRI scan, because somebody said you have a headache, let's order an MRI. Let me just see the patient and talk to the patient. So the patient came, the maid actually came to me. She said she described a headache in this area, in the frontal place. And when I did an exam, I touched here and there was tenderness. I gave her a course of antibiotics, course of anti-inflammatory medicines and analgesics. And within a week, her pain completely improved. So this was a classic example of sinus headache, sinusitis. So this is where proper diagnosis is important. Not all pain requires an MRI scan, the sophisticated test. Some pain can be easily diagnosed with good history taking and decent physical examination. And this is a pain that can be easily healed, completely cured. Case 2, patient with metastatic breast cancer with intense headache. This patient actually came to me with breast cancer. Now, breast cancer, when patients have intense headache, especially if this is associated with nausea or vomiting, you always think about cancer in the brain. So in this patient, I ordered an MRI scan of the brain, and lo and behold, there were multiple small metastatic deposits in the brain. So how did I then decide to alleviate her pain? I have to reduce the swelling in the brain by giving steroids, and I have to consider treating her all those lesions with radiation so that the growth can be arrested. And then I have to do something in terms of taking care of her cancer as well. So in this case, I reduced the pressure in the brain, in this cavity, in this skull, to alleviate her pain by using steroids. So for this, I required a sophisticated diagnostic technique, an MRI scan. Case number 3, patient with stage 4 colon cancer with pain in right upper quadrant and left lower quadrant. So this was a patient with colon cancer and intestine cancer who came with pain in the abdomen. Whenever I see such patients with colon cancer with an increasing intensity of pain associated with nausea, vomiting, I think about either cancer mass pressing on something causing obstructive symptoms, for example, bowel obstruction, sometimes causing neuropathy that causes pain. Sometimes just the pressure itself can cause pain. So in this patient, a simple X-ray of the abdomen showed that this patient was having bowel obstruction. So I just put her on fasting and put a tube down her mouth, down her nose, into the stomach, alleviated the pressure, gave her some bowel rest, and the bowel obstruction resolved with improvement in pain. Now, this is a very challenging situation to manage when patients have malignant bowel obstruction. But temporarily, I was able to alleviate her pain. Here, I did not cure the pain. I did not heal the pain. I just palliated the pain. Case number 4 is the daughter of a patient who came to me and said, my mother has brain metastatic cancer. She's constantly in pain. But I had a conversation with the doctor, and doctor said there are a lot of family dynamics, a lot of social issues. Husband not taking care of the wife when she was healthy, now getting sympathy. The daughter's overwhelmed. A lot of family forcing the patient to go to across the world to get cancer care, whereas the patient is tired of all of it. So all I did was I went to the patient, I spent time with her, established a relationship, addressed her spiritual need, addressed her emotional need, was able to then bring together the family and help in healing and realizing forgiveness for within the family, and also to involve a pastoral support so that there was some counseling. So with all of that, I was able to reduce the amount of opiates, the third level in the ladder, amount of opiates to control her pain, and she died peacefully at home in excellent pain control. The 5th case is a man with prostate cancer who is now cured but cannot sleep comfortably due to pain in the feet. Now, this happens when patients with cancer get treated with chemotherapy. This can also happen when patients with diabetes, when the diabetes is not well controlled. Patients actually constantly have sensations, weird sensations in their hands and feet, sometimes what we call neuropathy. So I put this gentleman on an anti-neuropathy medicine that sort of numbs the nerves in the body. It has some side effects, but we were able to then balance his side effects. So his pain improved, neuropathic pain improved, and he started sleeping comfortably. Again, this is one pain that I was not able to cure or heal, but I was able to palliate. So some of the barriers to getting good pain control is patient tolerance. The patients have to reveal, have to discuss. Caregivers, we have to positively impact the patient. Sometimes caregivers can negatively impact patient. Financial resources, you have to take the patients to some places. For instance, one of my patients with pancreatic cancer had such degree of pain that the patient had to be taken from all the way in Dicky all the way to Trivandrum in palliative facility and be given care inpatient. Now that took away substantial financial resources, which Pallium India was able to support. Resistance from doctors. Like I said, some of the corporate hospitals or anybody, I don't want to blame corporate hospitals, even government hospitals, because of ignorance from healthcare providers, doctors, because of lack of incentives, we don't give good pain control. We believe morphine has ceiling effect. We don't hike up the morphine beyond the level, and patients suffer from pain. So there are various barriers at the patient level, giver level, and the doctors and the nurses level. But here's where you can help. We must listen to our patients always. Remember what I said, whatever the patient says, that is their pain. We believe them. Talk to patients, family members, and caregivers. Sometimes the pain may be a total pain where you may address the physical pain, but there may be emotional pain left behind. There may be spiritual pain left behind. So think about all the pain that you see in your life as total pain. Think about the physical, the spiritual, the emotional, and the social contribution to the pain. Now emphasize multidisciplinary care. Sometimes I may need help of a nurse. I may need help of a wound care team. I may need help of an interventional specialist. So multidisciplinary care can help. Ask, always ask the nurse, ask the caregivers, ask the patient, ask the family member, what can we do to help? And don't underestimate pain ever. So I hope you got a sense of pain, its impact on a person, its impact on the society. And I'm happy to answer your questions. And if there are none, we will go forward to the next agenda, which is a case discussion.
Dr. Aju, I just wanted to ask that people often calculate their the pain and the physical circumstances they feel, I mean, in terms of their relationship with people and all that. They do make a spiritual calculation of it, that God is punishing me and God is against me and all that. So say they do interpret it in a spiritual dimension. So now, if I think in that case where you were able to involve a pastor was commendable, but how do you tackle it if they are from a different religious worldview?
Well, all religions have pastoral support one way or the other. I'll give you a classic example. A patient currently under my care, he belongs to the Islam faith. Now, he has substantial pain, multifactorial, multi-component kind of pain. Now, this gentleman believes in, is an ancient kind of believer, okay? So he believes there are people, you have enemies and the enemies can do voodoo. He is constantly telling me that, doctor, I know you guys can't help me. You're not helping me at all. I know somebody who can help me. Someone's doing this to me. So it is a very challenging situation for me to handle. So what should I do? Should I tell him, okay, you can go from the hospital, go check out this guy, the antidote to the voodoo? Should I leave it to them? Because I know that his pain is not from voodoo. It's actually from pleuritic chest pain, from liver meds, from bone meds. So it's multi-component, multifactorial. I don't have an answer, Abhijit. In this case, what I didn't do much because he got really sick that he's in the ICU now. But what if this gentleman is almost ready to be discharged? I think I have to play along. I don't know. There are no real correct answers to this question. It's very difficult. I mean, I belong to a Christian faith, so I have connections to the pastoral community.
Yeah.
So I can confide in them and say, hey, this guy is coming, just handle them well, just address their issue, sort of thing. But now this gentleman is from a very far away place. I don't know who is going to approach. So I can't call them up ahead of time and say, hey, just, tell him that all the voodoo is taken off. Don't worry, your pain is gone. But it's very challenging. Spiritual management of pain is very challenging. Now you brought a very important question, guilt. I myself have gone through it. When I have had situations in my life that, I felt were unusual health-related challenges. The first thing that I thought about is, well, God is punishing me. I'm educated. I have probably 16 years of graduate, postgraduate education behind me. 16 out of 40 years of my life. I've been in school, university, studying, I teach. But I too think about punishment, right? So sometimes it may be real, sometimes, most often it is just guilt. So I think that is where family support helps. I think it is where knowing, being part of a society, more education on pain as not a punishment, as the fact that we are alive, that there are diseases. So more and more as people become aware of the physical dimensions of pain, and that pain is an ubiquitous thing in this world, I think that guilt part will be taken off. But it is very challenging, extraordinarily challenging. Dr. Aju Mathew sir would always narrate a situation where they would constantly go see a gentleman who belongs to a fisher folk community. The gentleman constantly is in pain. No amount of pain medicines was able to address his pain. Finally, Rajagopal sir or someone in his team was able to break through this gentleman and was able to communicate well. And he revealed that his children, he was worried that his children may end up uneducated when he passes. So then the Pallium team was able to tell him, and they actually fulfilled the promise, that they will take care of the education of the children. And within no time, his pain is controlled. So that is a classic example of the social dimension of pain. So understanding total pain and addressing it in various segments will help. But thank you for answering that very important question, which I don't have a complete perfect answer, but this is as best as I can tell you.
Thank you.
Dr. Aju, we have another question in the chat box. Sir, how far is acupuncture and some other forms helping in palliation?
Yeah, so this has been highly studied. There are a lot of clinical trials that have evaluated integrative medical strategies. Now, you have to understand the words integrative and alternative. Alternative is traditionally quacks or frauds. Alternative, don't believe in these guys. They are mafia, medical mafia, pharma company sponsors everything that they say or write. Don't believe them. Go somewhere else. That's alternative. Now, I don't believe in that. The integrative, which is what is practiced everywhere in the world properly, and even I practice that, is where we use whatever is non-pharmacologically available along with whatever we can properly scientifically give to alleviate pain. So there are a lot of integrative medicine centers in major cancer centers, like the best cancer center in the world in New York has a big department. So all these guys have studied integrative strategies. The most studied integrative strategy is acupuncture. And in fact, that is the only strategy that have found to have some benefit in pain control, especially neuropathic pain. So acupuncture, I believe, helps. But the problem is, I don't know if people really get trained to do acupuncture here. So I don't even know whether I can. I mean, in the US, everything is scrutinized and regulated. Here, if I send someone to acupuncture, what if the needles are not cleaned? Will they come out with an HIV infection instead of controlling the pain? So that is my challenge here. So that is my challenge in practicing acupuncture or referring someone to acupuncture. So I think acupuncture can help. There are some good clinical trials that suggest that. None of the other modalities have been proven to have any integrative value. Yoga may help, but I don't know. Unfortunately, there are no properly conducted. When I say properly, I mean scientifically, rigorously, properly conducted clinical trials. I hope someone will do a properly conducted, not a biased trial to just prove that it works. But a properly conducted clinical trial may help, may show some benefit. I don't know. Does anybody know any acupuncture specialists who do a good job or personal experience of getting acupuncture done for themselves or for their relatives? None. Okay.
Yeah, sir. This is Srinivas here.
Yes. Hi.
Hi, sir. So basically, acupressure, acupuncture, there is a lot of literature which says in the pain, it actually helps. And I too have seen a couple of cases and some Ayurvedic techniques which are called as marma therapy, and those also have an impact on pain relief. But as you rightly said that we have seen in the form of a no randomized control trials or a meta-analysis, anything supporting that it's not been that at one level, but case studies, and we know some of the people who have gone, but that has to be substantial gold standard evidence is still lacking, sir. And as
Yeah.
you are a pain specialist, sir, what was according to the Indian Association for Study of Pain, they have recently modified the pain definition. So, what was the reason behind modification of that? And then how far with the change of that definition, uh, what needs to be taken care, whether it is been earlier what component was missing, now what component has been added, and how our perspective should change according to that.
Yeah. Now, thank you for your comments, Srinivas, about the integrative strategies, Marma, Chikitsa, and those kind of stuff. The second question that you raised, I'm sorry, I'm not competent to answer that. I'm not a pain specialist, I'm an oncologist. So I'm not very attuned to what is happening in the pain definition of the IASP. Now, may I please ask a Pallium India moderator to take down this question and discuss with the course director. The question is, recent definition for pain as per IASP, Indian Association for Study of Pain, has changed. How does the definition impact classes like this? You know, how do we teach? What is different? Essentially, that's the question, isn't it, Srinivas? What is the difference? What change has been made? Would you also email me when you have the answer, please? Because I am also keen to learn. Please, sir.
Maybe Dr. Raj can answer
Please
that.
discuss with the course.
Okay. Maybe Dr. Raj can answer that. We'll just get in touch with him.
Is he's not here. He's traveling.
He's come back. He's come back.
Okay.
He's in
Yes.
Bangalore.
Yeah. Please ask him to when he's free. I think this is a very important point that I am not familiar with as well. Thank you. Okay, shall we go to the case discussion by Dr. John C. James?
Dr. John C., please take over.
Can you please repeat, ma'am? I couldn't hear. Yeah.
Dr. John C., you can proceed with the presentation. There's a slight disturbance from your side.
Am I audible, ma'am?
You are audible, but there's a disruption in the voice. I think it's the fan sound.
Yeah, I think the fan is creating some disturbance.
Good to go, doctor.
Yeah, thank you. Good afternoon, all. I will go with my case presentation. So I will introduce myself. I am Dr. John C. James. I am working as a psychiatrist in Indira Gandhi Hospital, Kavaratti. Next slide, please. My patient is a 23-year-old male. He was diagnosed with the left parietal lobe astrocytoma, which was grade 2 to 3 histopathologically, status post left parietal craniotomy and gross total excision. Status post radiotherapy with adjuvant chemotherapy undergoing monthly cycle of chemotherapy 5 days per month, and he's a PG student in chemistry. Next slide, please. Medical history. He had history of sensory seizures, which was 9 months back. It was followed by 1 episode of generalized tonic-clonic seizures. CT was done after neurologist consultation. It was suggestive of left parietal lesion, for which MRI brain was suggested. An MRI brain plain and contrast showed left parietal of mass lesion, which was suggestive of intermediate to high-grade glioma. And the left parietal craniotomy along with gross total excision was done 9 months back. Intraoperative finding of the tumor was suggestive of grade 3 lesion. And histopathological report, however, was suggestive of diffuse astrocytoma, which is IDH mutant, WHO grade 2. Radiotherapy with adjuvant chemotherapy was done 6 months back, and currently he is undergoing monthly cycles of chemotherapy, tablet temozolomide per oral 5 days per month. Past history of social use of alcohol and tobacco. Next slide, please. Regarding the insight of patient and family, regarding the diagnosis, the patient and family was aware of the diagnosis as it was informed by the surgeons and concerned oncologists. And regarding the prognosis, patient and family was aware of the prognosis as informed by surgeons and oncologists. Palliative care was, the patient and family was not aware until they were referred by surgeons and oncologists to palliative care. The family overview.
Dr. Jonesy, when you
Yes,
said patient was not aware of palliative care, I didn't understand what you meant.
Because the palliative care options, that is the psychosocial management,
Okay. They were not aware.
They were not aware of such a branch in medicine.
I see. Okay, got it. Thank you.
Okay. So the family overview is his family comprised of his father, his mother, and his younger brother. Next slide, please. The echo map of the patient includes his parents, his sibling, other family members and relatives, his friends and teachers, his neighbors, religion, and community members. Next slide, please. Socioeconomic overview. He is a degree student in chemistry, belonging to middle socioeconomic status family. He is single. His father is doing agriculture. Mother is a homemaker. His younger brother is working as a staff nurse in a private hospital, and they had financial constraints and was supported by other relatives. And patient and family was aware of diagnosis, treatment, and prognosis. Next slide, please. Regarding the psychological overview, the patient had worries regarding illness, treatment, and financial constraints. He also had fear of recurrence of the tumor, the side effect of treatment, medications, fear regarding pain, and fear of death. Also, he was angry towards self and others, also towards the God. Also, he had sleeplessness. Next slide, please. Regarding the overall view of the total pain, physical pain, as I have mentioned in the diagnosis, it was left parietal lobe astrocytoma grade 2 to 3, status post craniotomy along with the gross total excision, and status post radiotherapy and adjuvant chemotherapy, and currently undergoing cycles of chemotherapy every month. Psychologically, he is having worries regarding the illness, treatment, financial constraints, fear about recurrence of tumor, side effects of treatment, fear of pain and death, and sleeplessness. Regarding the socioeconomic profile, he is a degree student. Middle socioeconomic status, he is single. He is single and his father is doing agriculture. Mother is a homemaker. His younger brother is working as a nurse. And the family is having financial constraints and they were supported by other relatives. They were aware of diagnosis, treatment, and prognosis, and spiritual issues, chaos, angry towards the God, and anger towards self and others. Next slide, please. Regarding the discussion points for today's session, the psychosocial assessment and the complete psychosocial profile of the patient, and addressing the psychological reactions, fear of treatment, illness, side effects, death, and all, and regarding enhancing coping strategies, communication with the patient and family, management, adequate management of physical symptoms such as pain, and psychosocial spiritual support, compassionate presence, and participating in the community for helping and supporting the family, and regarding the future plans for the patient and the family. Thank you.
The floor is open for everybody. If you have questions, thoughts, any things that you can suggest, please discuss.
Inviting everyone's comments to the case discussion. We have a question, Dr. Johnsy. What is the prognosis as of now of the patient?
As of now, the surgeons and radiologists have communicated the prognosis like every 6 months he have to do the MRI of brain, plain and contrast. So specifically regarding the lifespan and all, they have not mentioned. They told at least for 5 years, every semi-annual MRI is required for follow-up. Along with now he's completing 6 months of chemotherapy. 5 days in a month.
Dr. Johnsy, your
Yes,
slides
sir.
were very, can you bring me to that total pain slide? It was very good, really amazingly done. You put all the boxes in the right place, and in fact, this patient, everything is there, right?
Yeah, yes, sir.
They have physical problems, they have psychological problems, they have socioeconomic issues and spiritual issues. You know, this is very classic of the kind of patient that I see in my practice. In fact, I'm sure if you talk to any doctor who understands, willing to go to the emotional part of being a doctor or a care provider, they would realize that you know, most of our patients have all of these boxes somehow ticked. Young man coming to me, how do I manage the situation? Clearly, this gentleman, he has a high risk brain tumor, which is treated with a curative intent. Okay, that is very important. Whenever you see a patient, it is very important that you figure out within or a palliative intent. Now, treating with a curative intent, when I mean patient you're trying to treat to ensure a cure, that is, disease is completely gone. Palliative intent, you're only trying to alleviate the symptoms, control the disease. So the difference is when you treat for curative intent, we want to give the maximum intensity of treatment because there is the chance that your treatment can actually cure the patient. So in this instance, it is very important that this patient complete the course of treatment. It is very important that they don't fall from the treatment course because they can't pay for the treatment. So having a counselor, a social welfare officer, understanding what financial resources are available to assist people like him complete the treatment is very important. If this patient, like my patient with metastatic brain cancer, if that patient, the intended is palliation. So for instance, if my patient can't afford high dose radiation, I know that it is only for palliation. My high dose radiation, which may cost 1.5 lakh rupees, may not actually make her live longer. It may help, reduce a headache a little bit, but for that I have better pain medicines also. So I would think for that case, should I use up resources? Resources are anyway only finite, right? If I use up the resources that I have, that is money that I have from charity, from whatever, to then pay for that patient's treatment, it is being taken away from someone else who I'm treating with a curative intent. So understanding the intent of treatment is very important for us to counsel patients and for us to help them undergo the treatment and complete it. In terms of psychological well-being, one of the simplest things we can do as care providers, as doctors, as nurses, as pastors, and whatnot, is to offer them the promise that, hey, you are going through this not alone. I'm going to walk with you. I'm not saying I'm going to make it any better for you. I'm not saying I have all answers for you. But one thing I can guarantee you is that I will walk with you in this journey that you did not decide to take on your own, but was forced on you. So just saying does not matter, by the way. You have to, patients should realize that you mean what you say. So once they understand that this doctor or this nurse or this person is really honest and they really want to walk with me, then my experience is a lot of their emotional or psychological distress dissipates. Just offering my phone number helps reduce the psychological trouble very much, because they know that if something happens, I have a doctor just a phone call away, or a nurse who can be reached 24/7, or a hospital that would be receptive to my calls or to my concerns. So you see how some of these actually don't need medicines. They need financial support. They need to address some of these issues. They need financial support, thinking support, offering to assist support. Spiritual, ultimately, I believe some patients will just have to deal with it themselves. All you can say is, hey, this is not yourself. You're not walking on this alone. There are other patients that I'm treating who are going through the same situations. Don't worry. I mean, this is not something that you brought on yourself. Socioeconomic, again, counseling the family to understand that this is curative intent will matter. Counseling appropriately is important. To be available to answer questions is important. But excellent slide, excellent way to address patients, even if you're a doctor or not a doctor. I'm glad you brought up this slide. Other thoughts?
Hello.
Sir, I have a question.
Yeah.
Am I audible?
Yes. Afterwards, after that, Sunil can talk. Yeah, please go ahead.
So we see he's a student here and he's very young. So he has multiple psychological symptoms that he's been experiencing regarding the illness. So, like, how do you address somebody who is who's studying and is young and is part of a community where he should be going around with the friends and enjoying his life, but now he's he's surrounded by multiple somatic and psychological concerns which are very difficult. So what approach do you take in such young people with difficulty where it's also psychological and physical?
Yeah. So if again, coming back to what I just talked about, curative versus palliative. If it's a curative intent treatment, I just rely on the fact that I have cured the person. So I just offer them hope. I tell them that, I'm giving you real life situations. A patient with me currently, engineering student who's writing his final exams, he's undergoing chemotherapy for stage 1 testicular cancer. I know that the chances are I'm going to cure him. So I offer him a hope that, hey, you're going through some tough time. You're losing hair, you're not able to interact with your friends, you're not able to study well, but you have a job coming up. And I promise you 6 months from now, you will feel much better and closer to your usual self. It's going to be challenging for the next 6 months, but slowly but steadily, you're going to rebuild your strength. And by January, you'll be back to your normal self. So a hope. Here, I use the strategy of providing hope that, hey, few months down the line, I'll be back to my normal self. But I can't say this to a person with stage 4 testicular cancer who's young, who's has only months ahead, right? then that would be just lying, and that's not right. It will depend on how the curative versus palliative intent, what am I trying to do. And to set expectation, unusual that they're going through life's extraordinarily challenging situation, and that they have support, that they are fighting it as best as they can, and that the society is there to help you. Our society is not very proactive in that way, because if we come to here, a lot of my patients tell me, please doctor, don't tell anyone I have cancer. Because the moment they hear, they would come and tell me, hey, are you stage 4? How many more months have the doctor given you? The patient is probably stage 1 cancer. So they have to hide their disease diagnosis. In this instance, the young man, engineering student, I was able to talk to his college principal and tell him, hey, my patient is your student. He's undergoing his exams. He's undergoing his chemo. What can you do to help my patient fare well in his studies and spend his last few days in campus in a reasonably okay way? And the principal gave me full assurance that he'll do whatever it takes to make his life easier. That means, bringing the car directly to the front of the classroom, making exams easier for him, all sorts of assistance that can be provided. So as providers, as assistants, palliative care specialists or volunteers, there are a lot of things we can do. And the most important thing being proactively helping society understand that cancer is not always a death sentence. So don't look at our patients around us with sympathy, just empathize and support them in their walk. Sunil has a question.
Hello, am I audible? Hello.
Yes, you are. Yes, you are.
Yes, Sunil. Yes.
Actually, when we go to the community, we go with pain to understand the pain of the community people. And but the problem is like the community where I go to work are all de-addict with alcoholism. So when we go to the field to know their pain, they're not able to express their pain because if they are drunk or they are in a state of alcoholism, they won't feel free to come and share their problems. But they're able to express their pain when they have taken alcohol. So in this case, how do you try to extract pain from the community people?
Sunil, excellent question. You are 1,000, 10,000, a million times more competent than I am to answer that question. I am yet to work in de-addiction situations. I honestly don't know the answer to your question. It's as much answer that one can get. So I would like to hear from you.
Yeah, because Pallium team is also there. Yeah, team is also there. So since they have been working on this, as we are, this is a new concept for me. Pain, total pain thing, no. So it's getting more intense, and I'm much more eager to learn more about it.
Yeah,
and
I don't know.
Yeah. Anything, anybody from the host can have
moderating team. Can you support him? Can you ask the course coordinator, the director, whether we have any resources to help palliate chronic drug addicts, drug users, drug abusers, alcohol abusers, to express their pain in a community setting, not in a hospital facility.
It should be the community. Yeah, true.
I'm sure we will have options to give answers later on, right, moderators?
Yes, we can take this question and give it to the people who can handle it. I think we have a session on substance use and drug disorder, a session basically for that. So maybe the resource person at that time might be able to handle it much more better.
Yeah, if this issue is
discussed, please notify them so they can study. So please notify them so they can come back.
So when we are getting tutors who are teachings on these things and all, so if, during substance abuse, if we can cover this topic, that would be a great help.
Thanks. We'll look into that. Sure.
Yeah, just notify them. So Rajiv has a question. Rajiv's question is, how do we, that is general people, but I am also general people, advise about hope without knowing deeply about the condition? So it is challenging. So that is where you need to involve a doctor. the patient's doctor and understand. Very chronic issue in Kerala and India. Our society always provides some bad information to patients when the doctor knows what the real information may be. So always, try to reach out to the doctor. If you are not able to reach out to the doctor, then don't discuss that issue where you have half information. Okay, so yeah, really hope is something that the doctor has to really help out.
Yeah, thank you, doctor. I'd also like to add in, like, it's usually seen that some of the people who even do not know the condition of the patient goes in and tells the patient a lot of things, and sometimes it ends up being giving false hopes.
Yeah.
So I think that has to be
Yeah.
taken care of before we discuss something with the patient and the family.
Exactly. The problem I understand, Rajiv, is that finding doctors who can really communicate to the patient, finding doctors who can really communicate honestly to those who are really keen to understand is challenging. Doctors have limited time, don't have patience, don't have the skill, or just don't want to do it. So I hope as Palim India is able to train more doctors, we will breed a set of doctors who are very open to communicate to people about their illness, and addresses not just physical symptoms with medications, but addresses a person's problems holistically.
So I would like to add on to it. One example I can give you. I was part of one of the community projects in Bihar, where we were looking after people with chronic illnesses. I am from the same faith. I believe in Christ, and the team that we were working with has the same faith. So I have seen many a time when we talk about the spiritual aspect of the illness, many a time people from different faiths thinks of it as a curative treatment, like you pray and we be healed, because they take the Bible in that context, that when we'll be prayed for, it will heal. And I have seen many people practicing it in that way, which adds on to a false hope, and eventually patient being succumbed to the illness. And that leaves a huge log of trouble with the family and the care and the team that we were working with. So how do we address that area, sir?
Yeah, Ms. Manath, I don't know the answer to that question because I struggle with the same problem. I have lost at least 5 to 10 patients because of this problem. Patients who otherwise would have been cured, who believe that the cure will come spiritually and not through medications, and would forfeit treatment. Now, this problem is not just for the Christian faith. This problem is for all faiths. There are limits to which you can counsel them that, okay, God can work through medications, God can work through doctors. Ultimately, the patient takes responsibility. So I think educating, not becoming patronizing. I hope you understand when I use the word patronizing, not becoming condescending to patient, and informing or empowering patients to take their decision. At the end of the day, that is all that matters. After that, whatever decision the patient takes is theirs, their life. Our responsibility stops at the point where we empower patients with accurate information. The other side is they decide, okay, I have patients from the US, my very good friendly patient who died because after numerous emails explaining things, personal meetings, hours, she decided, okay, I believe in Christ, I'm going to believe that my disease is going to be cured. 1 year from now, then her cancer came back. But she was content with that. She took a decision after thought, after prayer. I empowered her to take a decision. She took the decision that then my responsibility is then to support her with whatever comes afterwards. So I don't have an answer how to help such people take a sensible decision. So, yeah, sometimes things work well. Recently, I just saw a patient, young lady, 21-year-old with ovarian cancer. So after surgery, she was advised chemotherapy. She didn't take chemotherapy. She went to the homeo practice. Homeo was fraud. It was not a real kind of homeo guy. It was a fraud kind of guy. And then after 1 year, she came back. Thankfully, the cancer hasn't come back. So her faith in homeo actually helped. Of that fraud homeo, I'm not saying the real homeo, fraud homeo helped. So some patients take decisions. She was empowered to take a decision. She took a decision that she thought is right for her. She lives with the consequences or dies with the consequences. So we shouldn't feel guilty about it as care providers. That's my only way to help you, Manav. One other problem that I see is when spiritually we have disconnect. For instance, I have certain worldview, the spiritual worldview, but when I go and see a person from Islam or a Sikh or a Hindu faith, the worldview may be different. They may think that reincarnation is there, right? I don't believe in that. So how does that struggle? How does that problem address each other? So I think that's where our professional boundaries should be kept. Where unless asked for information, we should not volunteer with spiritual information that would overrule their idea about the worldview. Professional encounter, professional visits, professionalism in practice is important in that kind of way.
Thank you, sir.
Yeah, Abhijit has a response to that. This is an unhealthy view. Unfortunately, in the Christian faith, I think it can be countered to imparting the right understanding of the Bible by a theologically trained Bible teacher. But yeah, it's challenging. Even the most educated people may have some different worldview, right? So as care providers, we can't impose. All we can do is empower, give them information, offer a second opinion with someone else, and there our roles will end.
So we have another question about that. So as an oncologist, do you use narcotics? Would it create the lack of insight in patients?
Very regularly. I mean, one of my most important weapon is narcotics. Probably as important as some of the chemotherapy that I use. I hope I would change. I hope things would change later, maybe 20 years later, when I would not have to use so much narcotics. I hope patients come with more early stage cancer than they come now. But right now, about 60 to 70% of patients that I see are end stage patients, stage 4 cancers, which means I will have to use narcotics. So it does not create lack of insight. Okay, patients can take very sensible decisions while they're on a morphine, provided they're not sedated with morphine. You give them the right control pain medication, they will feel happy, they will be comfortable to take better decisions. Srinivas?
Sir, can you hear me?
Yes, I do. I can.
Yeah, sir. Sir, you brought about 2 points when we are managing these kind of conditions about we have 2 kinds of approaches to the cases. One is curative and another is palliative. So how do you decide whether it is what kind of approach does fit into this case, whether it is about anatomy or the experiences what you carry, or is it there are any specific set of cancer related conditions which cannot be cured? Because there are certain conditions, if you see that surgeons do it as a total removal or near total removal of the tumor, but after a due course of the time again that sets in. So how do you choose which line of approach you are observing?
Yeah, so
that is one thing.
Yeah, we'll hold on to your second question.
Yeah,
I tend to forget when you ask multiple questions at the same time. I rely on scientific evidence and proven published research to guide me. For instance, stage 3 breast cancer. The chance of cure after just surgery alone is around 60%. That is 100 people with stage 3 cancer. They get surgery, remove the breast. 60 of them may get cured completely. Don't do anything. You give them chemo, we can probably change that number to 80%. Give them some other additional treatment, we can probably get it to 85%. Therein, our scientific progress stops. Whatever you do, 15% will have cancer come back. So as long as patient is stage 3 and not stage 4, I consider that the patient is curative intent treatment. My intent is to cure. Maybe 2 years from now or 3 years from now, the patient may come back with disease. That time I changed my strategy to palliative intent. So medical science and research and my knowledge helps me understand whether I should treat a patient with a curative intent or a palliative intent. So that is from my medical training. Second question.
Sir. So in the first answer only, see if it is like the whatever may be it may be a tumor, or whether it may be breast cancer, or it may be a colorectal cancer or anything. If it's in the stage 1 or 2, you mean to say that curative will be able to maximize the chances of him?
Even stage 3, even stage 4, some stage 4 also, if you treat appropriately and there is a chance for cure. When I say curative intent, I'm not promising 100% cure. I'm just saying, is there a chance that this patient sitting in front of me can get a cure? And if that chance is 1%, I'm going to take it as curative intent. But if I know that this patient sitting in front of me, from medical experience, from research, that if this patient sitting in front of me can never be cured, can only be controlled, the disease can never be eradicated completely, can only be controlled, then I treat them as palliative. So it's either greater than or equal to 1% chance, curative. 0% chance of complete cure, palliative.
Okay, sir. Okay.
Yeah.
Sure. Another question
if you're Srinivas or anybody in this group, if you ever want to see how I practice or see how oncology practice happens, just come work with me for a day or two. I'm happy to take you up as my observers.
Sure. Yeah, sir. I was
Kochi,
browsing through your profile,
Kerala.
Ernakulam Medical Center. Is it the same thing? Yeah?
Yes. Yes.
Yeah,
Yes.
okay. Sir, one more thing is, when we talk about palliation, there is a multidisciplinary care which has been addressing the patients in taking total pain care, everything. So as I am a physical therapist practicing, so and as an oncologist, what do you feel, sir? How the role as a physical therapist, according to your vast experience, what you have treated?
Yeah.
So in what ways a physical therapist can help the patient to do that? And along with that, I have another question also. I'll ask after this.
Thank you. So the question, physical therapy, at least 20% of my patients get an automatic physical therapy referral. Physical therapy is very, very important to alleviate distress. I'm not saying pain alone, but general well-being, conditioning, to reduce the lymphedema, to reduce the aches and sores of the muscle. So the problem, Srinivas, this is also expensive. Well, you may think, doctor, you are talking about expense. You give medicine worth lakhs of rupees, and you're talking about what 500 rupees or 1,000 rupees of physical therapy. But the problem is, I know it is not expensive, but the patient, they think us when I refer, one more clinic visit, one more expense, why bother? It's very hard to communicate to patients. Number two is about the importance, lack of understanding of patients about the importance of physical therapy. The number of times I communicate to patients, hey, you have lymphedema, go see a physical therapist. And the number of times they readily and voluntarily say, okay, doc, I will go right away, or maybe I'll go in a week, is zero. I have to force them. I tell them, doc, please go to see a physical therapist. This is important. Not now. This will be important 10 years from now when your arm will be this big. So please go. So communication. I don't know if this physical therapist, the professional society is doing a very poor job of communicating the importance to the general public. Okay, so yeah, it's very important but poorly communicated. Second question, Srinivas.
Yes, sir, exactly. You hit on the bullseye. The communication is the key, actually, because the patient, the one job you have done your job, but we are not doing our job properly. So that might be the reason we have to introspect ourselves. And other things, sir, in the WHO ladder, you have in that slide, you were mentioning that non-opioids plus or minus adjunct. So what do you mean by this adjunct therapies?
Sometimes steroids, sometimes neuropathy, anti-neuropathy medicines. So I think you will have a session that talks about this WHO analgesic ladder later on. That will give you more information, right, moderators?
No, sir.
Oh, no. So Yeah. So some of the non-opiate medications are NSAIDs, paracetamol. Those are the starting. Then you go to weaker opioids like tramadol. Then you go to the stronger opioids like morphine, narcotic opioids. So three steps. Some of the adjunctive medicines are anti-neuropathy medicines. Steroids can sometimes help. Dexamethasone or Visolon can help. Those are something called adjunctive medicine, something that improves the potency of the pain medicines. Okay, thank you.
Okay, sir. Thank
Rajiv talks about financial toxicity from overtreatment. I'll share my screen. So, financial toxicity is a very bad, challenging situation. Financial toxicity. So, you brought up a very good point, and I recently published a manuscript in Lancet journal talking about exactly this thing: financial toxicity in cancer care in India. So this is a big review, and there are, how does financial toxicity matter? So what we found is financial toxicity. Nearly 50% of patients in care in India go into catastrophic health expenditure. That is, they have substantial financial distress that they have to forego their non-food expenses, like they enter enter work earlier. So the risk factors of financial toxicity: low household income, use of private healthcare facilities, higher stage of disease, younger recurrent cancer, severity of the disease. These are all problems. The impact of financial toxicity on family: decreased expenditure on education and recreational activities, accumulation of debt, premature entry of younger family members to the labor sector. Some people may have to do overtime, part-time jobs, so eventually lead to poor quality of life, delay to therapy, and whatnot. So we have provided some measures to help with interventions to reduce financial toxicity, and at the patient level, obtain reliable information. So every patient needs to get good information, get a second opinion, discuss benefits and costs with the doctor, discuss advanced care directives for end-of-life care. Should a patient be on ventilator? So always when you have palliative care of cancer, ask about end-of-life care. If I get sick, should I be admitted to the ICU? Should I not be admitted to the ICU? Should I be given ventilator? Should I not be given ventilator? At the provider level, as a doctor, I should screen for financial toxicity. I must discuss potential benefits and costs. I must provide an avenue for open communication. I must collaborate with counselors and social workers. I must follow evidence-based care. I must choose wisely and avoid low-value care. I must give early palliative care for patients with cancer. At the community level, that is all of us, we should increase awareness of prevention, screening. We should get philanthropic support. We should use public health care financing in a judicious way. We can provide cost-sensitive lodging facilities. We can dissuade patients from getting alternative medicine. You don't know the number of patients they lose to frauds, alternative frauds. Use social media appropriately. At the policy level, there are a lot of things that the government can do. So this is a manuscript that we published in December. You can Google it out with my name, financial toxicity. Yeah. Any other questions? If not, we will conclude. Dr. Resi Mero I found him stretching, so like this, so which means things it's getting boring already. Dr. Resi, do you have any questions? You're the one who has been stretching because it's been tiring to listen to.
Sir, can you share your email ID or something in order to get in touch with me?
Sure. Now, where is the chat box? Yeah, okay. What else? What are the questions? Dr. Resi, do you have any questions?
No, sir.
Thank you. I just felt like picking you out, by the way. Sorry. Anybody else? Dinu? Any thoughts, comments to Dr. John C? I think he did a very good presentation. I'm very appreciative of it.
Yes, sir. John C, in the financial component of the total pain circle, he has mentioned in the physical only about the diagnosis and the procedures underwent. But due to that craniotomy, is he having any physical, like any weakness or any paralysis or anything like that, John?
Yeah, I forgot to mention that. Yeah, actually, thanks for pointing that. He had, after the surgery, he had a slight reduction in sensory perception over the right side of the body, that is right upper limb and lower limb. And also pain associated with the procedure, that is craniotomy. That I forgot to mention. My apologies.
Is he undergoing physiotherapy, John C?
No, sir. What he reports is, if on the left side he is able to perceive 100% sensation, on the right side he is able to perceive around 90% sensation. So he was not referred for physiotherapy as of now because there was no significant reduction.
Okay, okay. Sir, my doubt to the Matthew sir. Sir, some of the craniotomy patients over the suture line, they complain of this pain, which is like very excruciating pain. So how do you deal that, sir?
Along the suture line, well, maybe neuropathic component of pain. I mean, I'm not familiar with craniotomy pain much. I have yet to hear anybody complaining of pain from the craniotomy, but breast pain is very common. After mastectomy, there is a lot of neuropathic pain to it. Physical therapy is useful for that. Neuropathy medicines are useful for that. Redirecting or modulating the pain is useful for that. But craniotomy, I'm not very familiar. I have not had many patients complain of.
Yes, sir. I had a patient who had a craniotomy with the decompression of the lesion. She was having like one-sided hemiplegia. When we were treating her, when she tries to get up from the position, like from lying to sitting, she has that excruciating pain, and over a period of like a few seconds, she has that. After that, she feels the reduction in the intensity of pain, but that bothers her very much with the everyday activity.
Okay.
So our physical medicine and rehab, they have applied some cream, but due to which she was having like not that significant reduction.
Anybody else? Abhijit, you had a question?
Yeah, I just wanted to say that sometimes the religious worldviews of people can be very unforgiving in terms of they see it as a sum total of their past deeds. It's ingrained in the religious system itself, and so then the patient starts thinking he cannot escape, or this is the result of his past sins. So I would definitely say that as Christians, we definitely have the doctrine of grace that kind of stops that it's not by your past deeds, but by the grace of God you're saved and you're healed. But I think for people from other worldviews, if it is, I think people going through terminal sickness should be allowed to explore different religious worldviews that can give them relief. If where they're presently, it's not helping them, they should be encouraged to read up or listen to different programs that can give them relief. It's just my comment, because I'm kind of coming from that background, church background. I'm concerned about the spiritual pain part. Thank you.
Thank you. Any other comments, thoughts? We have 5 more minutes and we will conclude.
Sir, Dr. Aju Mathew, sir.
Yes.
I'm Rajesh. Yeah, I'm really
Where are you, Rajesh?
Rajesh from
yeah, I see you. Yes, hi, Rajesh.
Yeah, I'm working as a nurse in District Hospital Palakkad.
Very nice.
Yes, so I'm really appreciated your explanation about the treatment content and the strategy of providing hope really appreciate it. Yeah, it's a new content for me. So
Thank you.
I have lots of palliative patients go through in my daily working schedule. So
Thank you.
I will put it in my working atmosphere now. Okay.
Thank you. So
And
I'm being very honest when I say, if you ever want to come see me or work with me for a day, you're very welcome anytime.
Sure.
Just give me a call.
Yeah.
Or email and just come. I'll share my cell phone number. You can WhatsApp.
So you're working. You said you're working in Medical Trust Hospital.
Ernakulam Medical Center. EMC. Ernakulam Medical Center.
Okay, doctor. Okay. Thank you so
I have
much.
a small practice. It's not a big practice. It's a small practice.
I just want to. Sorry. I just want to add.
Yes,
as a mother, my son had to undergo 8 brain surgeries and a stroke. So it was like a period of 1.5 years. But because of addressing the pain in the proper way, that completely taken away the total pain from caregivers. So how comforting it was, because the pain of the client is addressed properly, and that was like such a relief for us. Support. Hello, can you hear me?
Binu, actually, you were breaking up. Last 2 sentences, can you repeat? So your son was undergoing breaking.
Okay.
Maybe if you can switch off your video for a minute, it will be more clear.
Yeah, you can switch off the video and speak.
Can you hear me now?
Yeah. No, sorry. Okay, someone else can talk if they wish to, and then we can have Dinu come back when she's logged in again. Now, does all the participants know each other? At least, is there an introduction session already done where they already greet everyone? Has that been done?
So this is the 4th session, but there has not been an introduction session yet. Yeah, but I think this is the first session that everybody has started speaking up. Maybe it's because of you, the way you interact with them. Thank you so much.
Okay. So, ma'am, actually, that was one of the feedback. Actually, you know everyone, or do you learn? Actually, that has to be there. Actually, that is like, we don't know anyone except Arvind or few of our friends. So if everyone can introduce themselves, so it would be very great to know each other and learn from each other, actually.
So what I suggest is, next time, maybe one of these times, maybe 10 minutes earlier, everybody log in and just say their names, where they are living in, what location, what do they do. Some maybe homemakers, that's okay. You know, that's also a job. And what is their hobby? One hobby. I think it'll be useful.
Yes, I will do that. So normally we used to have these introductory sessions, but then this time it's the course structure is modified to a way in which it's going to be in just 2 months. Previously, it was a huge elaborate course structure. So this time it's quite short, and then we had to like rush into it. We'll look into it. Thank you for that.
Okay.
I think Binu is with us. Binu, would you like to speak?
Yeah. Can you
hear me? Can you hear me now?
Yes, please. Yeah.
What I was trying to say is, like, as a mother who experienced the pain of my son, he had to undergo 8 brain surgeries and a stroke for a duration of 1.5 years. So properly addressing physical pain of my son, how that helped us, the parents as caregivers, to take away the total pain of us, because of addressing the pain really well in my child, that helped us to handle our pain, different areas of our pain well. So it wasn't happened in India, so they were properly treating, like, pain was considered as a major aspect of life. It's very important to treat that particular part. So that helped us a lot in handling our day-to-day life.
Thank you. Very valuable. Some of the powerful people in the world are those who have experienced some pain in their life, because that will motivate them to make a difference in someone else's life. So just like how you discussed that, you have experienced some issues in your life that has motivated you to learn more and help others. Same with me. So all of us have some situations that we have been placed in, sometimes, unfortunate situations. Learn from it. May you be used to make things easy for the next person.
Thank you.
Okay, I think we'll conclude. Thank you for this opportunity, Talim India moderators. Thank you for patiently listening. And I always enjoy taking these sessions. It's just that I'm finding it very hard to manage time. Thank you again, and best wishes for everything that all of you do or decide to do with this course. Some may just use it as a CV point. That's okay. Some may use it to learn something and help another person. But I believe the more we do this, the more we are spreading the spirit of palliative care, which is essentially living or helping everyone live a good quality of life. So I always remember, we have one life to live. We can live it peacefully and comfortably. We can live it, let me phrase it differently. All of us will die. That's the reality, right? You can live dying, or you can die dying. So there are differences. So you can, when you are going to die, you can always be depressed and sad about the fact that you're going to die. So that is die dying. Or you can live dying. That is, we're going to die. But all those moments that you have rest of the life, you can live it in the fullness of life. Now, what we as a palliative community does is trying to help patients choose that and not the other. Thank you.
Thank you so much, Dr. Aju, for the brilliant session. So you just shook the crowd, and thank you to Dr. Johnsy for the wonderful presentation. And thanks to everybody who interacted and made the session very useful. So thank you. See you all in the next session. Bye-bye, Dr. Aju.
Thank you all. I have shared the feedback link with you all. Please do submit it on time. And kindly submit your case presentations as you have 2 examples in front of you now. So you can go through it. Kindly submit it as soon as possible. Thank you.